So, with a slight delay, we are going to start. And I'm very grateful to all of you for being interested in the activities we are carrying out at the Forest Glade Center. Thank you for advocating for this therapy. I would like to remind you that Forest Glade is the Excellence Center in the area of treating of invisible trauma, meaning all the stress-associated injuries and trauma of veterans, members of their families, and a special category of ours would be working with people who lived through tortures and being in captivity. You know how many people of our beautiful people come back home from the front line and, using our experience, and that's the experience starting from summer 2014. We are working with people who've got experience of participating in the military actions. We believe that dealing with the consequences of trauma is necessary, and we need to employ all the possible methods. We shall not get concentrated on assisting just with one method or within one approach, one program, but use multimodal integrative approach, something we really use at Forest Glade Mental Health and Veterans Rehabilitation Center. Mental health support, medical assistance, and other complementary methods of therapy that are there to help the mental health improvement of those people who protect us. And for sure, there's this topic of some auxiliary additional methods that are being actively used in the world. So we can't be sitting on our hands and doing nothing. I'm always saying when we speak about those people who've got negative attitude towards looking deeper, more profoundly into this topic, they are treating it negatively to add some ad hoc methods of therapy, psychedelic approaches to therapy. I believe these people have never seen a person countering or fighting their invisible enemy, PTSD, or other disturbances. This would be a very lengthy fight, and as clinicists, we believe that we need to help these people to overcome their invisible enemy in the rear after coming back from the front line, after they protected all of us there. That's our duty, and that's going to be my motto, and I'm going to continue advocating for this topic, continue with the clinical research we've launched at our Forest Glade Center. And today you will see in what way it was happening, you'll be revealed certain insights, you'll hear the feedback of our clients, certain videos. You will live through this half a year, and we'll have a look at what way this treatment was conducted and what kind of new life it inhaled into the Forest Glade. And actually, all the physicians involved and all the people who were our clients were really inspired. I'm going to give the floor to my colleagues. We're going to have certain introductory and greeting remarks to start with. I would like to give the floor to Ihor Kuzin, Deputy Minister of Health of Ukraine. Mr. Ihor, a few words from you, please. Because actually the Forest Glade is a rehab center by MOH, Ministry of Health. Dear Ksenia, thank you so much. You asked me to be brief, and I will try to do my best, taking just a few minutes of your time. This is the greatest pleasure to be here and have an opportunity to have a look at the results of the clinical research on KAP, ketamine-assisted psychotherapy. I would like to tell you that PTSD is unfortunately such a disease which cannot be treated just pharmacologically, because the share of efficient treatment cases would be not more than 30%. That's based on the global data. Psychotherapy plays the key role here, but also psychotherapy cannot yield the desired result as well, which is why, in order to bring every Ukrainian, every service person back to their families, to actually speaking to their homes, to normality. And in order to resist that internal enemy, that's so important to use all the possible resources which are out there. And psychedelic-assisted therapy would be the therapy which is becoming more and more popular in the world. Ketamine was allowed to be used as a medicinal product in 1980s, but starting from 2019, it starts being used to treat the pharmacoresistant depression, and there's plenty of evidence base. There's a huge evidence base that proves that ketamine is really efficient to treat PTSD in certain cases. So this is great that on the basis of this very prospective, innovative center, we have a huge opportunity to have a look at the practical results, outcomes, and in what way you were working this way, introducing ketamine-assisted psychotherapy, KAP for short, or CAP. So we can be using all the possible medical and pharmacological methods to bring every Ukrainian to normality, and I'm looking forward to hearing the results. Thank you so much. And now I would like to give the floor to Tatiana Sirenko. She's Deputy Director of Forest Glade Mental Health and Veterans Rehab Center. She's responsible for mental health, and she's a psychotherapist. And the topic of countering PTSD is something she's really familiar with. Yeah, that's my hobby. Countering, fighting PTSD, that's my life motto, actually. Hello, everyone. I'm grateful that you found a minute to join us here today and listen to the reports about our activities. This is my greatest pleasure to see our dear partners, colleagues, some of our clients. That's really inspiring and valuable. And for sure, I would like to express my gratitude to the International Renaissance Foundation, IRF, because namely due to your support this became possible. And this is something really valuable. We are still making our first steps in this regard, and without you, we wouldn't be able to move forward. And for sure, and maybe I should have started with this, I would like to express my gratitude to each and every defender of Ukraine, those defending my motherland, and those who were protecting my country. We are here thanks to them and for them. And actually, we are facing this huge challenge and a huge task to help our defenders go back to normal. And I like saying that the traumatic experience of our defenders would be a shield, the shield that covered plenty of civilians. They've got these traumatic experiences behind them, and we don't have these traumatic experiences, namely because the defenders took this blow. And this is our duty to do something for them now and help them recover. When I was just coming up to this stage now, I thought back to our first therapy on psychedelic-assisted therapy, which was actually happening here. And back on that day, I got really interested in psychedelic-assisted therapy. Stas Hibidulin, a veteran, was reporting back then, and he was telling about his story of recovery. And I was really pleasantly surprised. I was crying. Why I was stunned? Because while listening to his recovery story with the help of psychedelics-assisted therapy, I understood how much time we are losing, actually. And people who've got PTSD, they never feel safe. And we are doing plenty of steps, making plenty of steps, and are doing our best in order to build the rapport and to build the trust. And actually, what we can achieve within several months with KAP is sometimes achieved within years if we're not using the right methods. And time is of value, which is why we have to use the best methods which are out there globally, which is why we are looking into these new methods, new approaches. And today we are going to share the results and outcomes of our research or study. Thank you. Thank you, Tatiana. And for sure, Olha Halchenko, manager of Civic Resilience Program of IRF. You are inspirers and the great support to us. Thank you, Olga. Thank you so much. Thank you for great introduction. International Renaissance Foundation, IRF, works in Ukraine for 35 years already. We're a charitable organization, and within this 35 years, we've joined significant number of various reforms, innovations, the up-to-date newest approaches, and actually free of charge legal assistance introduced by the Ministry of Justice, the national preventive mechanism to counter the torture in the places of deprivation of liberty. Plenty of things and plenty of programs implemented. And every time when we were working on that, we've heard a lot, well, it won't work. Well, that won't happen. In Ukraine, that will never work. How come you are investing your efforts? We've heard a lot of criticism, and people were sure we would not succeed. We were just nodding silently and kept on doing what we needed to do and in what we believed. And actually, at the end of the day, these reforms started yielding great results and started changing the reality for better for the Ukrainian society. And the psychedelic-assisted therapy, as I see this, would be a reform or a revolution of no lesser scale, which has got a huge potential to change the situation in Ukrainian society for better, in the first place for the military and for the veterans. And the program I represent, the Civic Resilience, is concentrated on support and assistance granted to veterans and military persons, the families of those missing in action, POWs, and actually all my friends, acquaintances would be, again, veterans and service members. Between ourselves, we are joking, saying it's difficult to find a healthy veteran because, participation in the military actions would have its imprint and the health can be destroyed. For example, the health of teeth, spine, and plenty of other things suffer first. And when a veteran has got a tooth pain, he can go to this clinic, to the dentist, and his tooth can be treated free of charge. But, whenever a person feels pain, they would like to find the ways to get rid of that pain. But just imagine this very veteran doesn't have access to dentistry office, and still, this person is going to be looking for some ways out. They would go to, I don't know, to somebody dealing with the herbal medicine. Will it yield a good result? I'm not sure, but at least the person will be seeking assistance. But now imagine this is not a tooth which aches, but the soul. There's chronic depression, which cannot be treated with just mere talks, and the pills do not work already, and the dosage is now at the maximum. PTSD is not easily treated, but the pain is there, and the person is trying to understand in what way to treat this pain. So why not offering them an analog to the dentistry clinic for them to be able to come to the center and treat their pain? I would like to tell you the truth. To be frank with you, I've seen some preliminary results of the activities of the forest glade, and it's stunning. For sure, we will hear the results, the statistics, etc. But to tell you the truth, studies like this, activities like this, gives hope to those who's got this mental toothache. Thank you so much. And also, I would like to give the floor to my dear colleague. The project which is being implemented by Forest Glade is implemented with the support of the International Renaissance Foundation for sure, but in general, Open Society Foundation, a big network which is based in New York, where we are involving the best experts from the whole world who are supporting Ukraine in the area of drug policy, in the area of reforming the drug policy, including the PAT. Dear Tadeusz, the floor is yours. He's representing PAREA, and that's the International Network of Psychedelics Research. He's going to introduce himself, and the floor is yours.
Yes, thank you, Olga. Thank you for having me here, and congratulations to the Ukrainian government, to IRF, to UPRA for the incredible progress you've been making. So my name is Tadeusz Hawrot. I was actually born 25 kilometers from Ukraine. I'm Polish. I was born in Tomaszów Lubelski and then grew up in Zamość, which is kind of nearby. So it's always a great pleasure to work with you for this reason as well. So I thought that over the next few minutes, I might be useful to give you a very brief overview of four main areas when it comes to psychedelics in general. So the legal basis for scientific and medical use, what's currently happening globally and in Europe regarding clinical trials, then what are some examples of existing medical use in selected countries, and finally, what are the efforts that aim at building healthcare system readiness for those therapies. So with your permission, I have a few slides to show, and I just want to start with PAREA, which I am the executive director and founder of. PAREA stands for the Psychedelic Access and Research European Alliance, and these are all, so we are a membership-based organization. These are all our members, including healthcare professional organizations and medical professions like Association of European Cancer Leagues, European Brain Council, European College of Neuropsychopharmacology, a patient organization called European Federation of Neurological Associations, European Psychiatric Association, and so on. So really bringing in professional societies, patient organizations, and a number of psychedelic foundations as well. With this in mind, I wanted to show this quick slide, and many of you are, of course, aware of the conventions that regulate and control the use of substances. And I should emphasize that they control and not prohibit the use, because the conventions allow scientific and medical research. You can see here an explicit mention in one of the articles of the two conventions in 61 and 71. And each country is then responsible for how it integrates these conventions through their own legal systems. And countries can define the parameters for the degree of control of substances at the national level, and come up with different mechanisms like rescheduling, like exemption for research, early access programs, and so on within the scope of the conventions. And indeed, different countries, we see different countries apply the conventions in different ways, and it depends really on every country, on their healthcare systems, on their public health priorities, and so on. And so this allows two things. The conventions allow for scientific research on psychedelics, and here you can see the number of active clinical trials according to different compounds and according to the kind of the clinical progress when it comes to clinical trials. And it's this bull-eye chart where in the middle you see psychedelic therapies, psychedelics that are approved. For now, we just have Spravato of Janssen. Of course, there is also ketamine, which hasn't been initially approved for mental health, but it's of course used off-label and is approved. There are already many trials in phase 3, so the largest trials, and then others. So really, and in Europe, we have over 30 trials or over 30 active trials. So as someone mentioned, the train has left the station. I think this is unstoppable. The science is really kind of very, very enthusiastic about the therapeutic potential, which is why there are so many trials. This is hyperlinked. I will share a QR code at the end of this presentation that you can scan, and then if you'd like to examine this in more detail, you can just click on this hyperlink here. In addition to clinical trials, there are a few countries that are enabling medical use. Canada a few years ago introduced special access program that allows compassionate use through Health Canada, which is an equivalent of the European Medicines Agency. In Switzerland, for more than 10 years, there is a limited medical use with thousands of patients that were already treated. Then there is Australia that a couple of years ago downscheduled two compounds, MDMA and psilocybin, for PTSD and for treatment-resistant depression, respectively. And very recently, just this Friday, in Czech, their parliament voted on enabling supervised clinical use of psilocybin also for mental health conditions. And I just wanted to share that this, oh yeah, this is, by the way, Switzerland, an example of the number of patients in the Swiss limited use program. So you can see how quickly it's growing. And now coming back to the Czech Republic, this is Politico Europe writing today in the morning about the Czech Republic, about psychedelics, that the parliament passed this legislation. It's also quoting me, mentioning that it is bringing hope to people. And we, as we know, we don't necessarily have a luxury of time and waiting more years. People need these treatments now. And I wouldn't be remiss not to mention, this is a bit off topic, but as you can see, the Politico is also writing about yesterday session in the European Parliament where Ms. Oksana Zbitneva from the Ukraine's Mental Health Coordination Center talked to the Health Committee. And I just wanted to mention that there is an idea that was born yesterday in the Parliament to have a new EU-Ukraine committee, which will now be considered. Again, if you'd like to access the full issue, there is a hyperlink and you will have a QR code to scan. And the last point I wanted to cover is that in addition to clinical trials, in addition to medical access, some countries are already preparing for the rollout, for the implementation of psychedelics once they are approved by the regulators. And 1 month ago, we saw a launch of multidisciplinary recommendations on the clinical use of psychedelic substances in Portugal, where I'm currently based. And this was co-authored, and the launch was attended by all the presidents of these societies. You can see here the Portuguese Society of Physicians, of Psychologists, of Pharmacists, of Psychiatry and Mental Health, and also National Council of Ethics for the Life Sciences. So all the presidents of all these societies were present at the launch of the clinical guidelines, which will be kind of governing the future use. And I know that also in Ukraine there is now an effort to develop a competence framework, which is really a very similar initiative. So I want to finish by showing this quote. This man, he is a chief medical officer of the European Medicines Agency. He actually last year specifically wrote an article on LinkedIn mentioning about this second chance to psychedelics, saying there's been this shift in the way they are perceived among academics and researchers. So I want to mention by saying that as we now in Europe are reconsidering our strategy toward mental health, I believe that Ukraine doesn't just have to follow, but you can actually lead, and you are already leading. So we believe at Parea that with the right vision and partnership, you can become a model for how science, compassion, and policy can come together so that we improve care for those who need it the most, including veterans. So with this, thank you for your attention, and I will leave this slide for a few extra seconds. If someone would like to scan the QR code, you can then have this presentation available for you to use. Thank you.
Let us have a round of applause. Tadeusz, we're very grateful for your support, for your role in the changes in Ukraine, because we do need that, like any other country in the world. We need to provide the best care for people who defend not only Ukraine, but the whole democratic world today. And I assure you that we, as a state institution for helping veterans and military people with invisible wounds, will continue on our struggle till the last drop of blood, if we may say that. because we'd like to bring them back to normal life and leave the war behind. But only as a good memories, only as a good experience, as a unique experience that people have lived through. So we are very grateful from our entire community. We are moving on to the results of our research, and this will be composed of three small lectures. It's going to be Oleg Orlov. He will show the scientific view on the results of the research, and we'll have two lead specialists of Forest Glade, Vyacheslav Zaika, our psychiatrist, and Lesa Bodrenko, psychotherapist, who are the forward leads in Forest Glade for this type of work. They are going to share their reflections and their insights regarding this research. And I think it's going to be a very interesting part of our presentation. So, Oleg, I invite you for the word. Good afternoon, everybody. My name is Oleg Orlov. I'm a scientific worker, a professional in this project, and I'm a scientific consultant in this particular project. So this is what I'm going to talk about. The purpose of the research, design, criteria, and scale, what was our results, and conclusions. First goal is to assess the effectiveness of CAT in this project. I'd like to say that it was done according to the international clinical researches. It's not particularly clinical research. There wasn't a double placebo-controlled experiment, but we added the research component because we require data and we to understand the results, and the more objective our understanding is, the better it is. So please treat it as it is. It's not a double-blind placebo-controlled research, but please bear in mind the results. Do your conclusions. I won't do any tips further. Design. What we did. It was open pilot non-interventional research. So Forest Glade provided a group of veterans who were to whom, or another way, who could go through therapy that didn't have any contraindications. We did the diagnostic picking up before, including during the ketamine-assisted psychotherapy and at the end. How the therapy went, I'm not going to do that because my colleagues are going to share. I only saw the numbers and I during more numbers. The samples were done after the third, fourth, and seance of ketamine-assisted therapy. There were from 1 to 4 sessions, and the number depended on the clinical picture, on whether the patients achieved certain results or not, and during the cooperation with them. And during the final diagnostical cross-section, after the last session, and then a month after the course, we did the cross-section. The inclusion criteria is first a diagnosed resistant depression. Please treat those cases of not only just depression, those were resistant depression cases. There have been 2 previous attempts of treatment with traditional methods that did not yield any results. And then passing through the international patients route, the colleagues are going to talk about. And the third point is informed consent for gathering personal data. It's polls and results that I'm going to show later. I had told that when we did the cross sections, on the right you have the algorithm of the patient's movement. After each infusion, we assessed the effectiveness of the treatment, and the clinicians together with the patient decided not to continue. Those would be the final diagnostic cross-section, or after 4 infusions, we didn't do any more. Tools that were used. Measurement tools, quite standard. It's PHQ-9 for assessing the depression level. Second is BDI, back depression indicators. And third, it is PTSD checklist for DSM-5. We had 3 women and 24 males, 27 participants in total. I'm going to tell later in indicators. We didn't check it by the gender whether it's working or not. It's age distribution. 30, 50 years is our average. And I think it reflects the contingent of people in the military and armed forces of Ukraine. Here we have the severity by the PHQ, because not by a Beck's indicator, because they're like similar results, and by PCL, it doesn't show severity, but in the literature there are recommendations on how we can assess severity of PTSD by numbers and orient what kind of condition they had. Usually it was severe depression and PTSD by the indicators, quite severe PTSD. The number of sessions that were required in total, most had 3 or 4 sessions. 14 or 15% had 2 sessions, and only 1 person had 1 session with ketamine. Those were the results by depression before and after. Before at the beginning and after the last infusion. There were the clinical answers, but in general, there was severe depression, and certain people even lost the diagnosis of depression altogether. It's a different depression scale. It's a PTSD scale here. There is a statistical value, and the effect value is more than 1.0. If somebody is not aware of the effect, is 0.8 is high effect, and 1.0 and further is the dynamics from session to session. The biggest dynamic we see after the first session of the ketamine use, and then there is a certain improvement of the symptoms, but clinical answer can be seen right away, right on the next day. This is the individual dynamics. We can say that it helped everybody. As you can see in the upper part of the scale, the spectrum, there are certain people, the condition of which even worsened slightly. But overall, the efficiency does not depend on the primary condition. On the initial level of the symptoms, there is certain correlation from mild to severe, and people who had severe conditions, they overall got better. Why not? Why so? We'll have to research in future. It's regarding depression. This one is regarding PTSD. We see that there are people that even had their condition more severe by 1 or 2 points, but overall, people got better. It's a relative improvement. You have up to 25% of people who did not achieve any results with CAT, or those who had improvement just before 5 points, or this worsening of the symptoms. The minimal mag, mag, the minimum should be at least 5%. It would be more than 80% of patients, and improvement of at least and a half, it's about 50% of the patients, and remissions, 30% of the patients. I remind you that those were resistant to treatment cases that for which the previous steps had not yielded any result. This is regarding the PTSD. We can see there is huge improvement in symptoms, up to 60%, but fewer people than during depression achieved remission. And here remission was defined as the average number by PCL. It would be on the scale before 30 points. So overall, we work. Here, at the beginning of therapy, at the last infusion, and the months afterwards. And 18 persons brought back their inquiries and would like to have data on all 27, but maybe my colleagues will explain why contact was lost with them. Maybe those patients did not need any clinical help because their condition got better. You can see there are dynamics of decline of symptoms in depression, and in the months it became even slightly better. About the post-traumatic stress disorder, average they got slightly better in the months, but there are people who got it slightly worse in after months.
And now we're having a look at the correlations, like what is influencing maybe even the personality of the physician, of the therapist. So it doesn't influence the number of the session, no, the age of the clients, no. Well, the intensity of symptoms, maybe to a certain extent, we need to look into it. We had 4 therapists, and actually the result was sustainable. So the conclusions, the pilot project can be considered a success because the majority of the clients were characterized by the significant clinical response. The cat has got potential in treating the resistant depression. We are going to continue with such researches. I know about yet another one which is going to be launched in Forest Glade Center, and yet another one at a private clinic. That would be great, actually, to get all this data together and analyze it to actually assess what kind of evidence we need further in order to develop certain guidelines. Speaking about the limitations of the research, this is not a full-scale clinical trial. We need to take that into account. We didn't have the blinded controlled group with placebo. That's going to be within our research with the representatives of Czech Republic, or Czechia. And we would like to have, for sure, more participants, including female participants. We would like to have more female participants in order to understand whether the gender was influencing. That's it, what I had to tell you about the results overall, and maybe the colleagues will go into some nuances and some details which would be more interesting. Thank you for your attention so far. I don't know whom to give the microphone. This is going to be you, Mr. Vyacheslav. Greetings, everyone. I'm Vyacheslav. I'm a psychiatrist of the Forest Glade Clinic. It happened so that I became the key specialist in this very area within this topic. I'm going to tell you about the medical part of this research. There is going to be plenty of information that's going to repeat what was mentioned by my colleague Oleg just now, so I will try to do my best not to repeat what was already mentioned. So the selection of the patients, well, that was greatly mentioned by Mr. Oleg. The status of the veteran, depression resistant to medical treatment, that's informed consent and opportunity to stay within the center. Then we were setting the diagnosis on the basis of DSM-5 because we believe this 5th edition is the most specific one, and we had some legal reasons for that. You can see 2 orders of the MOH which regulated this very decision of ours. We theoretically and practically could set 2 diagnoses from the depression registry. That's persistent depression and the major depression. We were actually conducting an interview as regards contraindications to CAP. We've developed the questionnaires which helped us a lot in our activities. I'm not going to go into details as regards these forms, the questionnaires proper. I just would like to demonstrate those to you. These questionnaires pertained to indications and contraindications. That's the basis, I believe, for any medical institution that wants to be active in this regard. Meaning, every medical center, every institution shall be entitled to decide whom they are going to be treating and whom they are not going to be treating based on what kind of specialists they have, based on their readiness to undertake certain risks and readiness to face certain unpleasant surprises. Let's proceed. Speaking about the results of these diagnostic interviews, we could identify 4 conclusions. Either the patient doesn't have contraindications for ketamine-assisted psychotherapy, they can be included to the program, or at the moment of examination, according to the available information, it was not possible to conclude. For example, the patient has got certain complaints, but they do not have certain medical examination of, for example, cardiologist or any other line specialist. Or at the time of examination, the patient had relative contraindications. For example, they were using certain medical drugs that can not go along with CAT. So, appropriately, the scheduled use of the medicinal products was stopped. Certain gap was there when these medicinal drugs were on pause, and only then the person could be included into the therapy. Or, clause number 4, item number 4, the person had contraindications and could not be included into the therapy. Let's have a look. After all the diagnostic interviews were over, a person was offered psychoeducation. Well, the psychoeducation was about CAT, what it's all about, and what the pilot research was all about at the forest glade. Psychoeducation was about the condition of a person and what can be used to improve the condition of that specific person, not just within the framework of ketamine-assisted psychotherapy, but in general, any other means, any other methods. And the person was making a conscious decision whether they would like to opt for this therapy. Well, appropriately, after everything was agreed with this person, the time frame, the actual time to come and get admitted was discussed. Then, after admission to Forest Glade Center, the further steps were dictated by the medical guidelines or medical protocol Mr. Oleg just mentioned, and that was drafted on the basis of appropriate orders of the MOH and appropriate up-to-date guidelines, meaning internationally recognized guidelines we are entitled to be using. So, some of this was already mentioned, and now I'm going to mention the steps which we're actually taking. First of all, that was the visit to the psychiatrist. What the psychiatrist is doing during this visit, everything I've already mentioned, actually, but it's done officially this time, meaning while the person is not yet at the forest glade, they are at the stage of selection, and this was not done de jure. It was kind of a preliminary meeting. The patient was not yet the client of Forest Glade Center. We could not provide an appropriate medical certificate with the diagnosis, so we had to repeat this very procedure as soon as the person was admitted to Forest Glade Center. We had all the information in hand. We met the person, and it was just officially done based on the information we already had, and maybe we've asked certain clarification questions. So, as a result of this research or of this examination of a psychiatrist, a psychiatric diagnosis was set, and the rationale was formulated. Then the medical checkup of the patient followed. Actually, either a psychiatrist or an attending physician can be conducting this medical checkup. Here we pay attention to the somatic environment, whether the person has got certain somatic contraindications for the use of this very method. The results would be the expert opinion of not a psychiatrist this time, but of any physician, because actually any physician can assess the somatic condition of a patient. Usually this would be either an attending physician or still the psychiatrist. Then obtaining the informed consent of a client, a conscious informed consent they are granting after they've been rendered all the necessary information. So, this is all clear here. Now, mental health screening, so psychological screenings mentioned by Mr. Oleg, preparatory psychotherapy sessions. At these very preparatory sessions, we conduct psychoeducation, the more profound one, and we try to shape up on the basis of the previous sessions a demand on the side of a patient, and our esteemed psychologists are responsible for this. And the goal of these preliminary meetings would be to already prepare a person for the sessions of ketamine-assisted psychotherapy CAP. And the result, the outcome would be the psychoeducation conducted and the demand on the side of a patient present. Then ketamine is prescribed in appropriate dose according to the guideline. And then we start using ketamine as stage 7. I'm not going to go into details as regards these technical details depicted on the slide. So ketamine is being used, and in the course of the ketamine session, 2 specialists are present. Usually this was a psychiatrist and a psychologist that were managing the patient on a constant basis, and they knew all the peculiarities as regards the demand of the patient, their request, what actually became obvious during the psychoeducation. Then in the course of this ketamine session, 2 times the patient is checked up by an attending physician to check whether there are no somatic problems 2 hours before the session and during the session. Well, upon the cessation of such a session, there is yet another checkup in order to assess the patient somatically. Well, this would be it on this step, and now we deal with the integration session. So, initially, this is kind of a declarative session. It follows the ketamine session, and the key goal of this integration session would be to really register the feedback of a patient. But, you know, usually such session takes place the other day, the next day after ketamine therapy, and all the insights of the patient were discussed. Then monitoring of the treatment efficiency or efficacy, as mentioned by Mr. Oleg Orlov, and criteria of decision-making would be the ones mentioned already. So I believe this would be it on my side. I've mentioned everything that seemed to be interesting. Thank you. What about the route of the patient? Could you show us that? Yeah, we have a short video. I'm going to try to launch it. That's about the route of a patient.
В день прибуття та оформлення візиту.
On the day of arrival and admission to Forest Glade, the patient meets a psychologist who's going to support them within the whole process. At the first stage, the patient participates in the preparatory sessions. During these sessions, they are meeting the well-educated psychologists in order to build the therapeutic alliance, discuss the goals and expectations of the therapy. And also, they are having a look at the ketamine-assisted therapy influence and actually the intention of a patient to achieve positive changes are discussed during the preparatory sessions. The informed consent is signed. Now, the ketamine session time. During this session, the patient is getting ketamine dose in a controlled and safe environment under the supervision of healthcare providers. Psychologist stays next to the patient during the whole session. Whenever necessary, a psychiatrist is present as well. A patient is looking inside inside themselves and is living through transformational changes in their lives. The next day after the ketamine session, patient meets psychologist to undergo integrational session. This is the time for reflections, discussing the feedback, the experience, and integrating the new insights into daily life. Psychologist helps patient to understand and properly use this experience to improve their emotional and mental well-being. In general, the patient stays at the center from 21 to 26 days, and they are getting 4 sessions of ketamine. It depends on the emotional condition and the severity of the condition of a patient. Dosage, the route of administration is determined by the psychiatrist, who is monitoring the condition of the patient and is conducting a checkup of a patient before every CAP. This way, CAP at the Forest Glade Center offers a reliable and comprehensive approach to treating resistant depression, thanks to a clearly structured route of a patient, which includes preparation, integration sessions, and ketamine sessions. Patients can more profoundly understand their internal turmoils, find new insights, and achieve significant improvements in their psycho-emotional and physical condition. Thanks to this approach, patients are getting opportunity not just to counter their depression, but to find a new way to recovery. Yes, and hello everyone on my side. My name is Lisa Bondarenko, and I'm a clinical psychologist at Forest Glade Rehab Center. I would like to share my experience of our psychologists team and the experience of our participating in the project. Some information is going to be overlapping a little bit with what was mentioned already, so I'm not going to go into details. You know, speaking about CAP, ketamine-assisted psychotherapy, I'd like to compare it to the repair of the road we are driving, because our neuronal links would be that very road we are building within our life, and whenever they are damaged, then a ride can become very difficult for us. And namely, CAP is becoming as an opportunity within the shortest time frame, repair that surface of the road, reconstruct the road for the driving process to become smoother. And this will improve the quality of life of our patients. The process of treatment, this is the structure and the stages, they were already discussed. I just would like to clarify the time. The first and the second preparatory sessions lasted from 60 to 90 minutes. The ketamine sessions would usually last for 40 minutes, and then the integration session discussing the experience, it lasted something like 60-90 minutes as well, and this would be the minutes indicated on the slide. The number of sessions and the use of ketamine depended on the indications we've countered in patient, and we were correcting the dose together with the psychologist, psychiatrist, and the patient. Well, this would be CAP stages. For example, here we speak about preparatory sessions. We can split them into 4 parts, and Vyacheslav mentioned a little bit. What's important would be to really build rapport and to create this feeling of trust, feeling of safety. Creating the safe space. Our psychologists paid a lot of attention to this. Psychoeducation, meaning explaining the process, what's happening and how, decreasing the anxiety, training our clients how to self-regulate, stabilize, ground themselves, for the patients to know how to ground themselves whenever they feel bad. And appropriately, plenty of time was spent to actually shaping up the intent. What is the intent of the patient within this therapy? What is the expected outcome? So this would be 4 key pillars of this stage. And what I would like to mention as well, that a very good preparation had proven to improve the efficiency of CAP and help patients to actually integrate it all into their personal experience. Important aspects of preparatory meetings are listed here. So this would be a signing of informed consent with the patient, testing in order to understand whether there is dynamic or no dynamics, discussing the possibility of certain touches of the therapist, because we need to take care of the feeling of safety, and the patient needs to be informed because there were various experiences, and in certain cases we really needed to take the patient's hand to hold them by the shoulder. So it was an important stage. It's important to discuss it all with the patients. There will be certain touches. Information about music, which is going to be played. Music is the conductor in this experience, and actually the properly selected music influences the experience immensely. And any issues which are still of concern for the patient. There were cases when the patient was really feeling certain anxiety, and in the course of these preparatory sessions we were explaining where it would be happening, what music is going to be played, whether the headset or no headset. So these are very important stages in order to really create the safe space to decrease the level of anxiety, because anxiety can prevent a proper ketamine session and, you know, to have a smooth entering into this experience.
The psychiatrist and the psychologist were present during it, and there was a checkup before the session. The first entry would be intravenous, so that we could see the reaction of the patient on the medication, how deep did they go into the experience, check their body reactions, and further injections was defined by a psychiatrist. Okay, there we go. And during the ketamine experience, the patient lived through deep transformational changes, like consciousness change, and those could be split into four main components. First would be dissociative and altered perception, visual and sensory alterations, informational and cognitive effects, and psychotherapeutic potential that the medication provides access to, for example, suppressed memories, suppressed emotion, and it provides capability of reliving and re-experiencing through the dramatic experience, and eases our further way for the psychotherapeutic work. Integration of the received experience is truly one of the most important parts of the ketamine-assisted psychotherapy, CAP, because the therapy is not just pharmacological intrusion, but the big role is played by the psychotherapeutic support, and we emphasize on that it helps to integrate the experiences in the everyday life. And the integration, the post-ketamine experience, is one of the key phases that helps the patients rethink, solidify, and use the received insights. And what we paid attention to during the integration. Accordingly, those were the emotional state of the patient, and serving their emotional stability after the experience, like what's happening to them, what rises, what drops, determining if there are any unfinished experienced or anxious stances, thinking through and reflection, and helping the patient of structuring the received experience, work with metaphors, questions that further the integration, then the practical use of the received insights. So what specific change could be happening in life, how the transformation of the intent goes, and then preparation through the therapeutic support for further integration in life, changing plans for the future, and so on. And here I'd like to talk about the feedback of our psychologists regarding CAP, and I'd like to state that our psychologists had not worked with ketamine-assisted psychotherapy before. All psychologists had undergone training with Mr. Garachik, and it was their first experience in such a project in ketamine-assisted psychotherapy, as it was the first experience for our patients. And the initial feedback, it is very important for me. It's from Irina Feofanova. She wrote me a feedback personally in Viber Messenger, after the finite session with her first ketamine-assisted psychotherapy patient. It was a veteran with a very tough experience who have been fighting since 2014, and the whole therapy itself wasn't easy. And it's very important that I like that what she said, that you can work for years without getting the insight that this veteran received in 3 sessions with ketamine. It is very important because this therapy, it expedites healing. Well, here is a feedback from Olga Naumenko. What she states is it's a big pleasure to see positive change that is visible for a psychologist, and it provides with motivation to work further. The quick positive dynamics that provide information for both the patient and the psychologist. And what we would like to draw attention to, that our psychologists say that it is important to have further support of the patient. It's good when patients, for example, go into therapy, they continue therapy, somebody continues with our psychologist, somebody is being referred to our partners, then it provides a more constant result. Here is my feedback. And when a person goes through this experience, person can feel easier and lighter, as if a cloud disperses and thoughts cease to be heavy and cease to have that negative power. And a lot of patients say that after the session, they first, in a huge amount of time, they could feel the life. They see colors, they see sounds, and they perceive themselves in a new way, and that is true. And it's slightly more interesting. Those here are feedbacks from our patients. I have had a feedback from a patient. He listed 12 bullet points. I couldn't squeeze everything in here, but it'll reflect here slightly. So, for example, my suicidal thoughts reduced by 80%. It's a huge success in 21 days. The feeling of guilt just disappeared. I understood that psychologists can be trusted, and that patient continues therapy now with other psychologists. My dreams changed. Now I see scenes from a civil life in my dreams, not frontline. I started falling asleep without sleeping pills, and I started experiencing positive emotion. I could crack jokes, which I couldn't before. Those are two other feedbacks from other patients. The overall condition improved, the feeling of safety, feeling of calmness increased, and I regained my taste for life. I wanted everything, and my eyesight and memory. Why memory improved, I understand. Why eyesight improved, I don't, frankly. That's a feedback of my patient, and I started feeling my body. I paid more attention to my needs. I started seeing colors in life, and everything else was black and white before the therapy. And apart from sadness and sorrow, I feel positive emotion, and I reach further my borders that shifted slightly, and I continue looking into myself and listening to myself. Lena Herasimyuk, call sign Hera, paramedic of the Voluntary Medical Battalion Hospitalier. Lena, why did you decide to turn to a new protocol of the ketamine-assisted psychotherapy? Why forced Glade, to be specific? If we describe days before the ketamine therapy in one word, I would use black as in color. That pressure that the war brought and the full-scale invasion, they broke me. I can give you this type of association for that condition. I was looking for a way out because 7 years during the war or near the war, they gave me not only the understanding how I was traumatized in this reality, but understanding how to work with myself. And unfortunately, the means that I was using before, they stopped being effective. And I started looking for a new way. I started looking for something connected to the conditions when, for example, uh, the pharmacology stops working, antidepressants. When you wake up and you don't have any means of self-regulation because negative thoughts, they like crawl all over you. I was looking for a way out from this condition because I think changed my personal character, and it was a reason for additional shame and additional aggression. I didn't know what to do with that, and my brothers and sisters in arms who had that unique experience, they started sharing their experience in the small circles, and I understood that that obviously was the format of treatment that works for people like myself, who have gone through a lot of means, but unfortunately the level of responsibility and conditions we were into, they made receiving help and by previous means impossible. And I saw on the webpage of the Forest Glade, I saw the announcement. The Forest Glade is a home that is our home for a while, quite a while, and in veteran circles there is nobody who wouldn't know about least Forest Glade. And within these walls, I have good memories. This is not my first time here, and the Glade was one of the first teams who raised the call that the calls and challenges that were before the veterans. I think that the Forest Glade was the first team that had the symbiotic view as on a shell shock and mild TBI as a trauma. It was very valuable as a person with combat experience that I saw how it affected my brothers and sisters in arms. And of course, because of this fame within the one small group, the level of trust to the Glade is absolute. And even in that black and emotionally reduced condition, I understood I would be accepted here, that I need to knock on this door and I would be helped, that the help that would change me. Thank you for your trust. What expectations did you have for the CAP before the treatment? Before the treatment itself, I had no expectations because I consciously was reducing my level of expectations. I repeat, because everything was black around me. And over the overall issue, the overall future dreams, they weren't even an issue for quite a while because I was under circumstances where I didn't even think about those things, and unfortunately, I had no energy to build any plans. And when I came, I understood that in any way I would need to try it because I need to go through to break this condition which I'm in, which I wasn't because I consciously did not build any expectations. It was my way to be open to each scenario before me. What were your emotions? What were your yeah, interesting emotions. I can say it was an easy walk. I can say it was just a rest. It's like re-experiencing and reformulating your experience on a different level, and one should be ready for that. Ready because, as we did do with the conversation, ready for the introspection and like hypnosis and work for previous sessions. However hard this experience would be, however or complex, at the end they provided the feeling of ease, the feeling of relief. Even though it wasn't a very vivid relief, they provided the feeling of physical basis. And each time when I woke up, I came up with a comparison that grew, I grew a new part of my brain that was tasked with reworking and re-experienced all the emotions my human nature couldn't do. What was your biggest impression about the ketamine-assisted psychotherapy in the process? I was surprised by the non-typical approach of this direction altogether. It's something that happens in Ukraine for the first time, I think. It's something where we, veterans, and first veterans included, and it's a reiteration of our story, and it was quite a surprise, like a television that is being played instead of reality, and very, very, very non-typical experience. It's something that a person can go through. A movie that you generate inside yourself and emphasize on what's important at this particular moment. And for me, what was very valuable was to live through dramatic events again, because in my imagination, everything that was valuable for me came back, but something I had lost unfortunately. And despite this heavy, heavy mood of this story, there was hope. And I think that this is all about hope. If we compare this therapy to a classic scenario, first thing that comes to mind is Fliv's scenario about how we get out from the epicenter of evil. It's about what we are after this situation and how we show this way to the others. The main thing is when you feel that probably you're out of energy, or this is the burden of the memory is too big, you need to remember what Orpheus had as a condition to escape hell. He wasn't meant to stop, he wasn't meant to look back. And this is something I'd like to share with my brothers and sisters in arms that are going to have the experience. Elena, let us continue further. I don't know why what wasn't playing. There was a video, but anyway. And I'd at the very end would like to provide a description of the clinical case of our patient. We received written consent, biographical data of the patient, and experience insights and data, and some details are slightly altered and for preserving the confidentiality of the person. Biographic data, for example, the name Oleg, 40 years, general education, lives in a big city, divorced, has an adult daughter. In 2024 was discharged from the Armed Forces of Ukraine, was in service since 2022, participated in active combat, in active assaults, and from the words of the patient has non-fixed mild TBIs, about 10 problems in the with the patient's words. Honestly, it's a problem for a lot of our veterans. It's inability to adapt to the civil life, inability to work the civil work, tried several times but didn't work out, and anger and issues with communications, insomnia, constant memories about traumatic events in the war, and avoidance stress associated triggers. The number of provided sessions. The patient received 3 ketamine-assisted sessions. There were 4 preparation sessions, 3 integrational sessions with psychologists, and 1 final sessions. Overall, there were 11 psychotherapeutic sessions in 21 days. And changes in the patient's conditions. After the first ketamine session, we see that we see a significant increase in sleeping, headaches disappeared, mood overall increased, and the intensity of memories decreased. Second ketamine-assisted session. The physical condition improved greatly, and the feeling of relaxation appeared, good sleep, no headache, and the level of irritability significantly changed. So what psychologists described, we can see that the patient became slower, as we could say, for example, slower in a way of slower acting, slower, and we call it become more quiet. parasympathetic nerve system started working and the overall relaxation kicked in. The third session, so the sleep overall was fixed, no headaches at all, no feeling of guilt, an acceptance of the past appeared, and relaxation, no irritability, significant improvement in memory, the level and vividness of the intrusive memories decreased, and overall the patient doesn't react to them anymore. And if we are talking about the integration after the third ketamine session, from the words of Oleg, the experience of the final ketamine session is a clear answer on how I can forgive myself. Like, what was in the past is no longer coming back. It remains there, and in front of me I have a lot of open roads. Choose any and go by it.
And actually speaking, for dozens of hours and for hundreds of hours, we are trying to bring the rationale to the level of feelings. You know, they say between this and this, there's 40 centimeters, but the road to achieving this is very lengthy. So with the help of CAP, within 21 days, we can achieve this very result, within which the veteran is saying that the past stays in the past. And this is becoming not just some philosophical, rational phrase, but this turns into an axiom. And this becomes, you know, like the basic idea. So the patient said, previously I was thinking about this, but now I feel it, I know it, and I accept it. And here we would like to show you the results of psychodiagnostics, where we were measuring using the scores. You can perfectly see the figures. So at first, with the scores are very high. So PCL, for example, 75 points. But after CAT, we see 31, then 25, and then in 2 months, the PCL level, the military version, is 23 points. So we can see that actually this has a prolonged effect. In what way it's going to persist, we're not sure, but this is not like a single result. We achieve it and then we forget about it. And if to summarize, I can tell you that we really understand that ketamine-assisted therapy is quite a promising area of treating resistant depression, and we can include PTSD here as well. And it demonstrates good therapeutic results, and it has very good potential. At the very same time, the efficiency of CAP depends on integration of the obtained experience, which will ensure a long-lasting effect. Meaning, without proper integration, we cannot consider this therapy as an option. And also, like a final summary to crown it all, we are asking a question: why ketamine-assisted psychotherapy? Why CAP? It's like, you know, the laptop, which requires reloading. The same with our patients who are getting stuck in their traumatic memories. So CAP is making this soft reload, which yields an opportunity to really reboot the system and bring back the healthy mechanism of thinking and to launch the healing. So this actually opens up new horizons in front of us. Thank you. And we still have a presentation of our great friend And our great mentor, Jerzy Goracek, is going to join online. He's a professor of Charles University from Prague, who's been using ketamine-assisted therapy for 30 years. Dear friends, do we have Jerzy with us? Oh, great. Jerzy, greetings to you. And thank you so much for waiting here, for joining us. And we are really looking forward to you taking the floor to crown up our great event. Thank you.
Thank you very much. Nice to see you, my friends. I'm greeting you from Prague, and the intention of my short talk today will be to briefly summarize our joint activities in the field of introducing the ketamine-assisted psychotherapy as the evidence-based treatment for PTSD. I have a little bit problem how to share my screen, so give me a moment how to do it. Yes. Is it okay now? Can you see my slide? My slides?
Yes, we can. Thank you.
You can. You can. Okay. So perfect. Okay. Be prepared together with Xenia and other friends from Forest Glade, the protocol for ketamine-assisted psychotherapy in military personnel. So this story began 2 years ago when I participated on the Czech governmental mission to Ukraine, and the intention of my traveling there was to identify how we can help in the field of mental health. Of course, we together identified the PTSD as the cardinal problem. During the war, PTSD affects up to 30% of people who are directly influenced by the war, both military and civilian people. And the problem with PTSD, I know that you are fully aware about this, is that it is very hardly treatable because both the drugs like SSRIs and psychotherapy has only the limited effect. So we put our forces together, and we established at the beginning the informal consortium consisting of Lisová Poljana, National Institute of Mental Health, Department Charles University, what's my major affiliation, and also the Czech Technical University in Prague, with the intention to develop and to test the very short ketamine-assisted psychotherapy protocol specifically designed for PTSD treatment at Lisová Poljana. The unmet needs which we identified were that it's necessary to target on very fast treatment because the pandemics of trauma-related problems is enormous. Of course, it's understandable. It should be easily administrable. So not only at Lisová Poljana, we only test the effect, but potentially in future to be shared by the rest of the Ukraine. Next need was to operationalize and simplify the procedure because we count on the fact that in future, when it will be used at other sites than Lisová Poljana, there will be also less experienced clinicians involved in that treatment. And of course, to have it safe and evidence-based. In this field, we utilized our experiences here in Prague with ketamine-assisted psychotherapy and with other drugs which have the psychedelic-like potential. We studied them in Prague I studied them for almost 30 years. We have a lot of papers in this field, but not in PTSD. We treat PTSD by ketamine only during the past 5 years, and we have the anecdotal reports for that. But ketamine is quite well established in the field of PTSD. There are several evidences that it really works. They are summarized. but as you can see, most of them are not complemented by the adequate psychotherapy. The problem why we need psychotherapy with ketamine is the fact that on the one side, ketamine is extremely effective in the treatment of depression and probably also other conditions like anxiety disorders and PTSD. This is related to the neuroplastic effect on brain synapses, but the clinical effect is quite limited. So we can expect without psychotherapy, the duration of the clinical effect, specifically in depression, lasting only for 6 days or up to 1 week. That's the problem. But if ketamine is complemented by psychotherapy, we can substantially prolong the effect, maybe permanently. Speaking about psychotherapy, which is used to complement psychedelics or ketamine, there are different approaches how to deal with the psychological support or psychological treatment complemented by ketamine administration. The most frequently used treatment is so-called psychedelic psychotherapy, which utilize the robust psychological effect, as the previous speaker very nicely described. So that's a psychedelic therapy. So to utilize the reactualization and the possibility to look from the different angle on the concrete mental condition which the patient suffers from. But it's also very attractive to utilize the so-called plasticity-oriented psychotherapy, in which it's used specifically the 1 week lasting window of opportunity when the brain is extremely plastic, and to put there the maximum of psychotherapeutic effort which we can. Theoretically, this plasticity-oriented psychotherapy approach can substantially shorten the psychotherapy and sustain the beneficial ketamine effect due to the mechanism of learning. The protocol, which I will share with you, or our protocol, which we conduct together with Lisova, with Ksenia and other colleagues from Lisova Polyana, complements both the psychedelic, the traditional approach, and the plasticity-oriented psychotherapeutic approach. I'll explain you how. If we combine the ketamine with psychotherapy, it's really possible to prolong the clinical effect. What you can see are the data from Prague psychedelic clinic called Scion, in which we primarily utilized ketamine. Our patients receive ketamine typically once, but complemented by 3 preparatory sessions, 1 infusion of ketamine, and 3 integrational sessions. By combining that approach with ketamine, you can see the rapid decrease of anxiety on the right chart, and on the left figure in depression, which is very rapid within 1 week, as expected, or within one day, but the effect sustains up to half a year. Yeah, that's extremely beneficial for severe form of anxiety disorders, depression, and PTSD. In Prague, we treated by this approach almost 600 patients, and these are the results which we presented last year at EMA SEC analog in Brussels. Ketamine, the legal status, maybe you mentioned it, is a little bit tricky because on one side, ketamine is used in as the anesthetics, and if we use it in psychiatry, it's definitely off-label use. But today on European and US market, there is also Spravato. It's esketamine, so 1 stereoisomer of ketamine. So the half of the traditional racemate, of ketamine, which is approved as standard antidepressant, and some colleagues in Prague normally use it on the daily basis. At our clinic, we prefer the traditional, the racemic ketamate, because it is almost 100 times cheaper, but theoretically we also can use the Spravato. Why I mentioned it just before, just to document that the ketamine treatment now belongs not to the experimental treatment, but the antidepressant and the clinical effect is well approved, and it's used as the standard treatment. So it's very important maybe for the people who regulate it. So the basic idea was to combine the ketamine infusion with EMDR psychotherapy, which will be which is administered by PC or by mobile application. Why not in personal? The idea is that in future we will share this protocol and the procedure with our other colleagues, and we want to spare the time of clinicians because the people who need this treatment at Ukraine, the number of people is extremely high. So this is the basic idea. Here you can see the structure of the treatment. As I mentioned before, the protocol is specifically designed for Lisová Poljana, where the people from army or veterans stayed for 3 weeks. So the treatment consists of 3 weeks protocol. It starts with the physical examination and comorbidity checking, then which is followed by 2 preparatory sessions. I think that 2 preparatory sessions is the minimum for the patients who are treated by psychedelics, but it's possible. 2 preparatory sessions is, from my angle of view, it's absolutely okay. This is followed by 3 ketamine infusions at the beginning of 3 consecutive weeks. These ketamine infusions would be or should be planned for the morning hours, because immediately after the infusion, or 2 or 3 hours after when the effect of ketamine is over, we plan there the first integrational psychotherapy, just to shorten to maximum the protocol. Yeah, we are testing the very effective and economic protocol, and the ketamine administration in this week is followed by 5 EMDR sessions in 5 consecutive days. So that's the basic idea, and this block will repeat three times. So after 3 weeks of active treatment, the patients we will check if the treatment is effective or not. Because we expect that all patients will be dismissed from Lisová Poljana after this. The follow-up period of 3 months is designed only in remote way. So we will call the patients and check their status, and or we will contact them by social media, etc. So this is our protocol. Speaking, which is based primarily on neuroplastic approach for ketamine-assisted psychotherapy, but the psychedelic approach that we deal and interpret together with the patient, also the symptoms induced dissociative and psychosis-like and psychedelic symptoms induced by the ketamine, it's necessary to integrate them. So we plan there 1 integration on the next day, the day after the infusion. So that's the idea. In my view, or in my experiences, it would be better to have more integrations, but 1 integration is the minimum. Yes, that's a standard approach, for example, which we use when we treat here our patients with depression or PTSD or anxiety disorders. So preparing the protocol was very demanding for all of us because we are facing war, we are facing the problematic situation. And for example, for me and for my team in Prague, we were not aware how the standard procedures are set at Ukraine. So at the beginning, we prepared together with colleagues from Lisová Poljana protocol and informed consent for the treatment. Next step was to sign all necessary memoranda with you and our university and National Institute of Mental Health and obtain financing. At the moment, the study is fully financed by Czech private sources, but in future we have open doors for next financing for other upcoming studies or protocols which we can introduce to Ukraine. But now this study is completely financed not by the governmental money but by the private money. Then we established the team at Lisová Poljana and in Prague, and we start to consult with Ministry of Health, State Expert Center, institutional review board, ethical committees, etc., how to approve the study. I think that we were together with Ksenia almost pioneers in this field, because this study definitely belongs to so-called academic randomized clinical trials. Yes, not the commercial one. So we had to overcome several problems, but finally we find the way. So the study was approved by the Ukrainian Institute of Public Health Policy as the representative of ERB. Then we have the statement from State Expert Center of Ministry of Health of Ukraine that this study is non-profit one. It primarily focused on psychotherapy assisted by ketamine, so that for example, the side effect monitoring and other necessary steps could be done by the institutional ethical committee of Lisová Poljana, which has been established for this purpose. So we found quite easy and practical way how to cope with all the administrative needs. Next step was to prepare the electronic case report form for the study. It's very important. It's a very important thing, because we follow the EU recommendations, and all the study is absolutely the same at the same design idea, and all the steps are the same, are congruent with European rule, which I think is quite important for you, because it opens the possibility to collaborate and to continue with such form of collaboration. It has been necessary also to establish the data security for the data, because we are in war, of course, and establish the monitoring at the Czech and the Ukrainian part. What's next step now are to find the insurance company which will insure the study. I think that it would be possible, that it will be possible because we have the money for this, and sign some contracts. Next thing which is important for such form of study is, of course, training experts. So we are in close contacts with our friends from Ukraine, and last summer we held at Lisová Poljana the first ketamine-assisted psychotherapy training, which consisted of 2 full and very demanding days. when during the first day, the participants of that training were acquainted with the basic principles of psychedelic-assisted psychotherapy, pharmacology of psychedelics, and the principles of set and setting, which is absolutely necessary for such form of deep dive into for the patients. We had there also some training on body work and how to deal with the body as the part of the psychotherapy. And this first day of training was followed by the next day when we discussed the practical things of our protocol, which we hope will be running within few days or few weeks. Sorry, we'll be able to start the study there. This is, I think, that the drastic impact of war on mental health during this war calls for more intensive help from our side and from the side of EU for you practically in this field. So we also run other accompanying activities to support our collaboration, both on at the Brussels side, in the Brussels Parliament, and also in the Czech, and also in the Ukraine. So last year in September, we had a meeting in Lviv called Innovative Solution in Mental Health, where we specifically discussed this thing, and we also held some high-level international conferences here in Prague. Maybe you can recognize here some of your friends. So we also monitor with colleagues the mental health in Ukraine. That's other activity which is only weakly linked to ketamine. Me, together with two very talented journalists, run the qualitative analysis on mental health, and specifically on mental health of mental health professionals. So months ago, we released this report. I hope that you have access to it. If not, please let me know. It was published in Czech and in English. We are waiting for the Ukrainian pay, and this report consists of dozens and dozens interviews with Ukrainian psychologists, psychiatrists, social workers, and others who were interviewed specifically in this field. So I hope that our collaboration will be fruitful in future, and I'm looking forward for your questions. Thank you.
Jerzy?
Yes, I'm here with you.
Thank you very much for the presentation of our future project, and I hope that it starts soon. We look forward to it, and there were a lot of preparation that has been done, a lot of preparation stages, so we're looking forward to our further meetings. Thank you very much. Friends, please come, everybody, all our psychotherapists, psychiatrists, everybody who's engaged, Tanya, Anya, Ola, everybody, not everybody in the room here, but I'd like you to see all those people here engaged into the process. It's not everybody, not everybody managed to come. Please come here, don't hide. Here they are. Here are the people who were engaged, who provide a lot of input, who lived here, and they were constantly on the phone in our internal chats. So there's a lot of work in front of us, and we are happy that we can present today. Who else do we have? Tanya, come on here. Tatiana, our nurse, who is very actually engaged. Nurses are utmost important. And our chief nurse, Tatiana, you can see her here. She plays a huge role when we're receiving a license on or having psychoactive substances. And so we are here, we do not stop, and nobody is stopping us. Thank you very much, friends. And We also have some time, maybe somebody has questions, some reflections, or feedback for therapists, for psychiatrists. You can ask your questions here. Yes, please. Thank you very much. My name is Roman Avramenko. First of all, thank you very much for great presentations and for enthusiasm of everybody engaged to this topic. I'll have two brief questions. First, maybe to Mr. Oleg Orlov. During the last integrational session, before measuring the level of input in a month, was in their intermission, was there any psychotherapy, or were the participants just released and left to their own devices? I'm for about numbers, about people go to psychiatrists. I think I can tell that there were different ways. Some of the patients went into psychotherapy, somebody didn't. So to determine the measurement, like for separately for psychotherapy or without therapy, no, we cannot like give you an answer to this question. Okay, then the second question, I'd like to add from my side that this is a very important part that wasn't reflected in the design of the research, and we need to pay attention to it so that psychotherapy and integration could continue in time after the finish. So if you remember, Oleg Orlov showed certain data that reflect that some patients did not have any change in their condition, or even there was one patient who had their condition exacerbated. And there is explanation this could be avoided and results could be improved even further. This is a different topic. I would like to stop it at the moment. Another word from my side, it's a very subjective experience, but among those patients with whom we continued the psychotherapy in a month, the results improved further. With my personal patients who did not continue psychotherapy, well, there wasn't any big improvement in a month. So this is a subjective experience which is not very representative. However, we should add one more important part, that all the patients that had treatment that were prescribed with Brentolix with medication that they are supposed to take during a certain period of time. Yes, thank you very much. The second question, not addressed to anybody specifically, what would you suggest an educational facility for those who would like to be a clinical psychologist and continue to develop in psychedelically assisted psychotherapy? Well, there are a lot of institutions that offer such clinical specialization of a clinical psychologist. I am not very sure what I would, for example, suggest. I, for instance, study at the Freud Institute, and I like it. I like the course, the curriculum. It is quite substantial, so I do recommend. Ukrainian Catholic University, good curriculum, good institution, good setting. Where do you study for ketamine-assisted psychotherapy in an institution? There are no institutions as of right now, unfortunately. When we finish work on this project, we'll provide methodological recommendations and also Heal Ukraine Trauma. There is a project on training ketamine-assisted psychotherapy, but I'm not very sure they're going to gain people. Mr. Rajic taught us personally. Maybe he will continue with this course, but there is no established program. Mr. Roman, cooperate with Lisava Polyana or the Forest Glade, and we'll provide you access to such studies. Why not? Can we continue? Yes. Konstantin Dubchik, Center of Mental Health, Kiev Mahila Academy. I have two or slightly more questions. First, a question about numbers. I didn't understand at once that assembling the group, the sample, was just random and in the streets. And how many people do you have? How big was the dropout? Yeah, that's a very good question because there were two. We took a quarter, I think. Here, psychiatrists took care of the draft and the people for the research. So with 10%, we got 10% of the inquiries. If it not for the design, we could have probably admitted more patients, but not everyone who filed an inquiry. Yes, thank you. We'll talked in the beginning that this method of treating the resistant depression, how did you assess the resistance, and was there how was it checked? We are not doing we're not treating the medication resistance therapy because we're not a psychiatric institution in a traditional sense of this word. So the medication-resistant depression was either diagnosed before, or according to the medical history data and medical documents that were provided by the patients, we were diagnosed in resistant depression because we had the grounds to do that. Thank you. And the last question about the conclusions and philosophy. Enthusiasm. I hear quite enthusiasm about this method, and as of right now is the third line method, third line therapy. Do you think it should become the first line therapy? Why should we waste money on depressants on 10 years of therapy if in 3 sessions we could achieve more? Ksenia Borisovna maybe would like to say a word about this? Well, I don't think so, that it should become the method, the first line, as in treatment of all, for example, conditions. We start with something simple, and if we are talking about treatment, stress-associated treatment, that we need to bring back the feeling of I can to the patient, and where we can bring it back with psychotherapy without using additional substances, that's fine. Where it doesn't work well, then it is experience to engage something that requires additional intrusion. That's my perspective on that. If you may, I'm going to add. I'd like to emphasize on the FDA instruction on using ketamine. And contraindicators, there are only 2 contraindicators. Is individual sensitivity and reaction to the medication, or allergy, in other words, or conditions that are threatening to the life of the patient, life-threatening conditions. 2 contraindicators. And by this primary use, ketamine was used in the first aid and emergency medical aid, and in gynecology during abortions. So it's quite a wide spectrum anesthetic in traditional medicine, and ketamine-assisted psychotherapy adds quite a substantial component of psychotherapy to this medication. So we're not asking during the emergency medical procedures that is this the medication, first line medication? No, we don't ask that. So I'm not sacralizing this method in any way in medication, but I wouldn't like to devalue it as well. It's one of the possible tools in the kit of psychiatric and psychotherapeutic help, psychological psychotherapeutic help, I apologize. It should be provided as a choice for every patient. I would like to add the same here. The psychotherapeutic methods don't work for everybody. For somebody likes CBT, somebody likes Gestalt therapy, somebody likes client-centered therapy. And as far as I know, during the comparison of the effectiveness of these methods, they did not find out that one method would be better than every other. So it's the same here. I agree that there should be a kit or the arsenal of methods. I first would like to thank you for all the work done, and say that you're doing great work, that your enthusiasm, I wish your enthusiasm is endless, and because there is a lot of work in this field. And the question, from the psychotherapeutic perspective, do you have any observations or ideas about the comorbid conditions that could be an obstacle for recommending ketamine-assisted psychotherapy? That's the first question. The second, whether this publication going to appear in any medical journals, I'd like to see it. And third, what do you have any other plans and designs about studying ketamine-assisted psychotherapy within the forest glade? Thank you. There are some contraindications. They are all included in our questionnaires that we give before the ketamine-assisted psychotherapy. And the main contraindication would be psychosis, schizophrenia, everything connected to psychosis, because the ketamine itself could be the catalyst for it. And somatic contraindications, we do not take people with depression. Oh, sorry. We take people with depression, I apologize, with epilepsy, with heart, heart conditions, people who live through cardiac attacks, with heartaches. Pregnancy is a contraindicator, and some other contraindicators, for example, intolerance of the medication, and, for example, if a person takes medications. We subsequently lower the dose and remove before the ketamine. It's more like.
May I ask another question here? Vladislav Sinigovsky, psychiatrist, XPO Clinic. And I used to be a military psychologist. I have a question about dosing. You were mentioning you use 0.0 milligram per kilogram. That's intravenous, IV, and intramuscular. What was the dosage within the framework of intramuscular administration? So dosage is of paramount importance here. And well, that was the first one. Okay, we didn't change the dosage depending on the route of administration. The dose was the same. The first time we had an IV droplets infusion in order to assess the response of the patient. And whenever there were some troubles, complications, we were pausing with this administration, or we were introducing dexamethasone and any other medications needed. But speaking about dosing, it acts the same, but the peak of action in IM administration, it comes into force sooner. And in case of IV, it's more extended in time. Well, speaking about the group, have there been active military personnel? Because I know that plenty of active military personnel was also admitted to Lisova Polyana or Forest Glade. No, just veterans, because, you know, after this project, the person might find themselves in the area of military actions, the re-traumatization can happen. And by the way, the person who had deterioration of their condition, it happened with them, though de jure they were not in active military service, they were a veteran, but de facto they were performing certain tasks, and they were keeping this information secret from us. So de facto, he was performing certain military actions. Okay, so for those in active military service, this is not the method of choice, and you don't see prospects of using CAP for them. Yeah, I don't. Yeah, for sure, for sure. Not for those in military in active military service. Hello, I'm Marina Saritsa, and I'm a family therapist. I'm sincerely grateful to your team for the incredible work, for the quality of your services. And on every slide of yours, I felt this expert approach, and I really felt safe that you were really doing it for the sake, for the benefit of our defenders from the bottom of your hearts. My question is going to be related, you know, to the relations, so to say. Why? Because maybe there are some guidelines or protocols colleagues were sharing already as of the moment of integration. Is it possible at the moment of integration to use family therapy element? Because we all understand that depression, PTSD would be those conditions that influence relations in the family and capacity to build relations. And we all see that there are challenges for the families. Have you considered this, and is it actually possible to discuss it and to think about it? If we include members of the family to the integration integration session. It can boost the efficiency of the therapy at the stages of resocialization, adaptation, etc. Thank you. So my experience of CAP tells me that the substance really helps internal development, some submerging into yourself. And within the framework of a project like we had, I mean, the project which is not long-lasting, well, this might be a good idea. It influences the openness, the feeling of the safe space. I don't know, maybe Vyacheslav has got anything to add here. May I comment on the protocols first? Have a look. There are the international clinical protocols, and they speak just about the duration and the dosing. But, you know, in practice, this is quite a new method, new approach. So, you know, there are still discussions. What would be the best therapy? Somebody is saying AMDR cannot be used in this combination. Somebody is saying no, just AMDR. So whether we are going to have combination of ketamine or some ketamine and some methods of therapy, this is still an open question. You know, there are no hard prescriptions there so far in the protocols. Maybe it will take up decades. Okay, various psychotherapy methods were mentioned, but please add here the peculiarities of a personality of a psychotherapist. And these questions are becoming even more complicated. I don't think there will be some clear-cut recommendation included into the protocol. That's it. That's all I wanted to add. Oleg was mentioning that some number of patients were lost to follow-up and you didn't manage to contact them. Maybe this question was asked because I was leaving the room for a minute. Have you got a hypothesis what happened to these people? Why they disappeared from the radar? Well, this is not they disappeared. We sent questionnaires to them, and due to certain reasons, they didn't fill them in. But they filled them in after the data was compiled and analyzed. You can see that 30 people were covered, but 27 people's answers were included because, for example, there was yet one patient who was finishing the therapy till the end of May. They're all alive, they're all out there, but maybe someone left, someone didn't have an opportunity to fill in the questionnaire, but we're monitoring the situation and having a finger in the pulse. Yet another question of marketological nature. We understand that destigmatization is important for this issue, and maybe some PR, some promo among veterans. Have you done anything like this? Maybe those people who had very good feedback about CAP, maybe you can offer these people to become ambassadors of this kind of therapy among their brothers and sisters in arms in order to decrease the load on, I don't know, maybe not even decreasing the load, but for more people to know about this kind of therapy among veterans, because people trust their own, may interfere with the criticism of what you're offering here. Then we have a question, the ethics, to what extent that's ethical to offer this to people who just finished the therapy and they are not really eager to spread the word. Maybe my colleagues will comment, but I have this ethical issue here. That's a very tricky question. And yet another tricky one. On one hand, we speak about stigma and destigmatization, but at the very same time, we need to speak about the correct approach within this method and what it should look like. You know, it's not that you go, get some ketamine, and that's not enough. You need a psychotherapeutical support, management, and in this promo, as you were referring to it, it's important not to forget that we are not PRing the use of certain substances. We have to realistically describe for the people to have the realistic expectations, because I already see some danger in this. Colleagues? Yeah, I'd like to continue with what was mentioned by Oleg. You know, in general, the peer approach usually has certain risks. On one hand, there are plenty of benefits because it's really the credit of trust. But on the other hand, there are plenty of reservations because we are supporting the evidence-based approach, not the protocol use, and we are sticking to the professionalism. There are patients who are ready to spread the word about their experience, and we are open to support them in that if we really see that we have the same values in this process. And as the communication officer, I'd like to add that we are, to a certain extent, doing this. And maybe you've seen it on the website of Lisova Polyana Forest Glade. We supported people who wanted to share their feedback and insights. And in the course of the whole project, we were involved in advocacy campaign in order to overcome stigma and explain to what extent it's important to take care and to have an appropriate approach to using this method. Hello, I'm Sasha Stutsenko. In the first place, I would like to express my gratitude to all your team for this great work, because I believe, well, actually, it's my dream for psychedelic-assisted therapy to become a reality for those who require it. And I don't like the word cases. We shall speak about destinies here, destinies of the veterans of war, for them to come back to normality. When Lisa was reading the feedback, that was a wow, and that's very important in your work. Thank you for that. And my question, it will go to Ksenia, I believe. What are the next steps of this research? And Task Force Glade plan introducing a ketamine-assisted therapy as the method of treatment. Do you plan to do that at the level of group therapy? Because individual therapy would be quite expensive, and Heal Ukraine Trauma is actually offering something like this. And the final question would be about funding. From the viewpoint of MOH and the Health Service of Ukraine, will there be some funding, not just covered by grants and the RRF? Sorry, I just joined you guys. I heard just the last question. No, for sure, it's only possible with the support of our international foundations. For the National Health Service to fund it, well, you know, MOH is not funding the treatment, just the National Health Service is doing so. And in order for this to be funded by the state, it has to be included as the method of treatment into the protocol, into the guideline. Ketamine is not yet there in the protocol, but we feel huge support of international partners, international organizations. This can be a huge kickstart now. We don't have that much money in our country, so international partners' support is really covering this gap. What else was asked? Yeah, speaking about group therapy, this June we plan to launch these activities with Heal Ukraine. And in general, speaking about further steps, Professor Garachik was mentioning the further steps in the next project we plan to implement. And actually speaking, whenever we are working with certain methods, we actually try to profoundly understand it, and we take what best can be offered by this method. And our first experience tells us that group sessions are good. We are very satisfied with the effect, with the prospects opened up in front of us. And we would like to improve further this very method. backs to the room, turning our backs to the room so far, but we are having a selfie. Great! Hooray!